Okay. Good morning, everyone. Bon matin. My name is Karen Lynn. I'm the Vice Chair at Kawasaki Disease Canada. And on behalf of Kawasaki Disease Canada and the U.S. Kawasaki Disease Foundation, welcome to our session, Navigating Kawasaki Disease Together, a dialogue with experts for patients and caregivers. I'm so glad that all of you could join us, both in person and online. Thank you to the IKDS organizers for allowing us to be part of this important session as part of the symposium. And a special thank you to Ms. Sabura Kawasaki for joining us today. We are so honored to have you here, and I can speak for every KD patient and family worldwide when I say that we are eternally grateful to your father for his care, compassion, and dedication to Kawasaki disease patients. Being a KD parent, I understand how challenging it can be navigating life after your child receives a KD diagnosis. The unique journey continues from childhood into adulthood with numerous obstacles along the way and seemingly no roadmaps. So we are honored to be joined today by two esteemed KD experts to help guide us as we travel this often complicated and unpredictable path. Dr. Nan Trong and Annette Baker are here to share their valuable insights with us. Unfortunately, Dr. Ray Young was unable to be here due to some unforeseen circumstances. She was very disappointed and sends her regrets. During the second half of our session, we will have an in-depth Q&A period, and we'll be taking questions from the attendees joining us in person and online. In-person attendees, please state your questions until the end, and online attendees, please feel free to ask your questions using the Q&A function. It's my pleasure and honor to introduce our first speaker, Dr. Nan Trong. Dr. Trong is a pediatric cardiologist and associate professor of pediatrics at Children's Healthcare of Atlanta and Emory University. She specializes in echocardiography with clinical and research interests in Kawasaki disease and pediatric COVID-related heart disease. She has been site principal investigator on several multi-center Kawasaki disease studies, and she co-leads two multi-center studies through the Pediatric Heart Network, long-term outcomes after the multisystem inflammatory syndrome in children, or MUSIC study, and the COVID vaccine-associated myocarditis, pericarditis, or CAMP study. So welcome, Dr. Trong. Thank you so much for being here.
Can you all hear me online and in the room? Thank you, Karen. Thank you for IKDS and the various family support groups within Kawasaki disease. Pleasure to be here today to speak to you about, I think, a topic that's pretty important all throughout pediatrics. I'm just going to do this so I'm short. I'll go with the camera there. That's probably an important topic all throughout pediatrics. This idea of transitioning from pediatric care into adult care. And I think there's been a lot of interest more recently, just because I think historically we've been doing a pretty bad job at that. And so I think overall we need to do better. And finally, it's been getting attention. And as I kind of speak about all this, I think one of the big things is I think we're all kind of a team in this transition. It's teamwork between the clinicians, patients, caregivers, everybody kind of working together to kind of help see our kids into adulthood. Okay, so, and this will be pretty informal. Please feel free to ask. Well, we'll get them at the end. So let's see. Not advancing. Here, we'll do that. Okay, so I have no relevant disclosures for this talk. So at the end of this talk, hopefully you'll have a better understanding for why we recommend long-term follow-up in children with Kawasaki disease and coronary artery involvement. And again, understanding the importance of healthcare transition and understanding the steps and elements for successful healthcare transition from pediatric to adult providers. And so many in the room are probably well aware Kawasaki disease is the #1 cause of acquired heart disease in children in developed countries. And from the talks that I've heard over the past couple of days so far, sounds like incidence is increasing within developing nations, while other pediatric cardiac diseases, acquired heart diseases like rheumatic fever, incidences seem to be decreasing. Kawasaki disease is diagnosed in over 60 countries at this point, and I've always tried to find out information on how many people in the US are currently living with Kawasaki disease. And it's probably whatever number we found, it's probably an underestimate because there have probably been cases that have not been diagnosed. And again, this is a very, very rough estimate, but I saw some data that in 2022, there were estimated 22.4 million children in the US less than 5 years of age. And so in the US, there's an incidence rate of about 18 cases per 100,000 children less than 5 years of age. I did the math. I'm not a math expert, but I was getting about a little bit more than 4,000 cases that year. And if things stayed pretty stable, over 20 years, we'd have at least 80,000 children just in the US, or 80,000 people just in the US who've had Kawasaki disease. And again, this number is going to increase as more and more children along the way are diagnosed and living with it after having been treated. And so in terms of the burden of coronary artery aneurysms in Kawasaki disease, which is the main reason why cardiologists get involved and sort of what the long-term picture most focuses on, because aneurysm development is the most highly linked with long-term outcomes in those with Kawasaki disease. So in the US, about 30%, and about 40% in Japan have coronary artery Z-scores over at least 2.5 Z-scores. And about 5% have Z-scores greater than or equal to 5, which would be in the sort of moderate, at least, aneurysm category by the American Heart Association categorization. And so, as I mentioned, the long-term outcomes in Kawasaki disease are greatly affected by the severity of coronary artery involvement. And the worst outcomes are in those patients who've had large or giant aneurysms, meaning a Z-score of at least 10 or actual dimension of at least 8 millimeters. And even then, outcomes are worse if your Z-scores are higher than 10. So some data from 2020 from the International Kawasaki Disease Registry, looking at the percent of patients with narrowing of the coronary artery itself. And you can see that, I don't know if you guys can see, here, I'm gonna step up here. So those who have coronary artery Z-scores less than 20, but greater than 10, so still within the giant aneurysm, but just within the giant aneurysm category, they have the least frequency of narrowing of the coronary artery. However, as your Z-score increases, the percent of narrowing of the coronary artery increases, okay? And that stays pretty consistent over time with 10 years follow-up. So looking at the percentage who have thrombosis or blood clot development within the coronary artery, again, if your Z-score is between 10 to less than 20, the percent that have blood clots within the coronary arteries long-term is less than maybe 5, certainly less than 10% at 10 years. But if your Z-score is over 40, and again, the higher your Z-score was, the higher the risk of blood clot development long-term. So what do our parents or caregivers and patients need to worry about in the long term? So what does that mean to have narrowing of your coronary arteries or blood clots? So what we worry about that translating into a clinical picture is having decreased blood flow to the heart, okay? And so decreased blood flow to the heart can lead to actual injury to the heart muscle itself, what we call a myocardial infarction, or in typical terms, a heart attack, essentially. And these arrhythmias can be developed, which are abnormal heart rhythms, decreased squeeze of the heart, or potentially even death. And that being said, death related to Kawasaki disease has been reported at less than 1%, but again, that's probably underestimated just because of missed cases of Kawasaki disease that have a sudden event. And I think it's important for families to realize that just because the size of the coronary artery returns to normal, quote unquote normal on echo, doesn't mean that the coronary artery itself is normal at this point. And so studies have shown that regression to normal dimensions of the coronary arteries occurs in about 75% of people who have had Kawasaki disease and coronary artery involvement. But again, back to normal doesn't mean that they're normal and you don't need follow-up anymore. So what we worry about in the long term is that in patients who've had coronary artery aneurysm, and again, that risk is higher, the higher your Z-score is, that you, as what happens initially is that the coronary arteries themselves, the blood vessels that provide oxygen to the heart, become inflamed. Cells kind of invade the cell wall to help weaken that coronary artery wall. And so your coronary arteries enlarge during that period over time. At some point, though, that inflammation has kind of died down. But as the coronary artery heals, it can develop this, what we call myofibroblastic proliferation, which essentially is in scar. Okay, so just like you have an injury on your skin, you can develop some scar essentially within the coronary arteries. So even though by echo, the coronaries are measuring normal, they're actually, they might be, the wall itself might be thickened and flow within it might actually be narrowed. So, and it's for this reason that multiple guidelines within different countries recommend that children with Kawasaki disease and who had coronary artery aneurysms, even if the dimensions have regressed to normal, need lifelong follow-up within cardiology. Now, this is a statement from the American Heart Association and also Japan, just to name a couple of those associations that recommend long-term follow-up for patients with Kawasaki disease and who have coronary artery aneurysms. So, you know, hopefully our children are living for a long time. And so how do we get them from the maybe infant or child who's had Kawasaki disease to the hopefully aged adult who's had Kawasaki disease in a healthy and happy way to get there, I guess. So again, highlighting the importance of this, in 2021, the American Heart Association put out or published a guideline statement, Falling Through the Cracks, the current gap in healthcare transition of patients with Kawasaki disease. And we have the honor of having Ms. Annette Baker, who's one of the authors on this here within the audience. So Annette, please chime in if I've said anything incorrect. And so what are the benefits of having a structured transition of healthcare? So overall, studies have shown that having a structured approach to transitioning our patients from pediatric to adult care, and not just for Kawasaki disease in general, improves overall health, not only within the child himself or herself, but also on a population level. So there's improved adherence to care recommendations, improved self-care skills, and improved quality of life. And also improvements in the experience of the care that the child to adult receives in terms of higher satisfaction of care and decreases in lapses of care. We want to make sure is that these kids that are now adults continue to follow with the medical team. And then also improved healthcare utilization with increase in outpatient visits for routine follow-ups and less hospital admissions and lengths of stay, which is obviously what we all want, to stay out of, our kids to stay out of the hospital and our patients to stay out of the hospital. So the statement notes certain components to structured healthcare transition. And the three main components are planning and preparation, the actual transfer, and then integration into the adult healthcare system. And to achieve these three components, the statement notes 6 core elements, which has been described in other plans as well. So policy, tracking, readiness, planning, transfer of care, and transfer completion. And we're going to go through a little bit of that, but within the statement, there's this nice little figure to kind of walk us through that. And I'm going to walk you a little bit through that as well as different ages at which that should start as kind of a roadmap, if you will, in terms of for both families and clinicians to kind of get us to that next step. And while the guideline statement was written sort of more for the provider to help plan the transition, like I said, I think part of it is a team, and I think knowledge for parents and caregivers of what to ask, what to expect is actually really important to the process as well. So planning and preparation for that healthcare transition. So one of the important things is start discussions early. So let's not wait until children are 17 or 18 years of age to start, oh gosh, what happens next? We want to start this early, even around 12 to 14 years of age, to start thinking about and bringing up with your cardiologists if they haven't brought it up. So what happens when my child gets older? What's the plan for long-term follow-up? And so that part of that policy is does your healthcare provider have sort of a roadmap for how, or is there a programmatic transition setup within that provider's office that helps to transition pediatric patients to adulthood? And then tracking. So when is the child ready to talk about their diagnosis and teaching them what's called self skills in terms of talking to healthcare providers, asking questions of healthcare providers rather than having their parents ask those questions. And then again, this assessment of transition. And so hopefully your provider is checking in on those things periodically, which includes kind of asking questions like, so do you know why you come to my office every year, or why you come to my office every 6 months? Again, your child might not know right off the bat, but the hope is that over time, he or she will have more knowledge and feel more comfortable with the understanding and asking questions. So the transition readiness. So again, your provider having a standardized process for preparing the child for healthcare transition, and again, monitoring those skills, planning, developing the plan with your child and you to kind of help what works best. So part of that actual planning towards closer to that actual transition is identifying an adult provider. And and I'll go into this in a little bit, but also your pediatric provider can help to develop medical summaries, like almost like medical passports, some have described, that has the diagnoses and kind of issues that your child might have had along the healthcare journey. And also emergency care plans. Again, one of the biggest things that we worry about is heart attacks. And so what if your child develops chest pain? What should be done in that situation? And early, in the patient and kids who have persistent giant aneurysms, they might already have this sort of emergency plan in place already. Also, and again, making sure that your child's records are with the adult provider. So hopefully there is good transfer of actual care of medical records, and also conversations are really important between your pediatric provider and hopefully the new provider to allow for questions and back and forth dialogue. And so this idea of transition readiness, again, kind of emphasizing that hopefully it starts at a young age, where the idea of transitioning of care starts at an early age. And then again, helping the child understand what the diagnosis is, what we look for long-term, what symptoms to report, for instance, and then things that I've kind of gone through. So we'll go ahead and skip. So one big question that families probably have is, who should my child follow in the long term after they transition? And I think that will be dependent on several things and sort of multiple discussions with your pediatric provider. Ideally, it's an adult cardiologist who understands both coronary heart disease and the unique issues related to Kawasaki disease, mainly because, heart disease in kids with Kawasaki disease isn't necessarily the same as adult onset heart disease. And so there are subtleties and differences that hopefully the adult provider who will be taking over care has an understanding of. And that's the thing, some people live in rural areas and might not have access to someone who's very familiar with Kawasaki disease. And if that person isn't available, pick a provider who is willing to ask questions, who is willing to contact your pediatric provider to ask questions and seek out support from others, and phoning a friend can help with all of that. And also, similar to things like in other situations where you might live in a rural area where an expert might not be. It might be, sometimes you can work out situations where there's a local provider who has close contact with a more expert person in a bigger, more populated area. So there are things to work out. But again, your pediatric provider, pediatric cardiologist can help work through all that. And so for the transfer of care, that entails having a follow-up with an adult clinician within 3 to 6 months of leaving the pediatric provider. And again, hopefully there are conversations during that time to make sure that transition has occurred smoothly. And then the transition completion is when there's been confirmation that your child has followed up with the adult provider. And during that time, it's important for you to provide feedback to your pediatric provider. What worked, what didn't, so that the pediatric provider can refine the process. And I think having parental input and caregiver input into those processes are extremely important, because I think what I've found over time is what we think parents, patients, and providers need is certainly not what we always think of. So on the flip side, there's also an adult, for the adult that's taking over the care of the child, the now young adult, in terms of how to integrate that young adult into the adult care system as well. And I can share that link with anybody. And so in summary, children with a history of Kawasaki disease and coronary artery aneurysms require lifelong follow-up by a cardiologist. And healthcare transition is of vital importance as children with Kawasaki disease and coronary artery aneurysms are getting older. Successful transition can be achieved, but requires time and planning. And as I mentioned, I really think it's a team effort between parents, caregivers, patients, pediatric providers, and adult providers to make that transition successful. Thank you for your time, and happy to take questions.
Session after I present the next.
Oh, okay, great.
Thank you, Dr. Truong, for your outstanding presentation and invaluable contributions for Kawasaki disease research. As a parent of a KD child, staying informed about research developments such as those you provided is crucial. Good afternoon and buenas tardes. Elizabeth said I have to present in Spanish, so that's my Spanish part. My name is Vanessa Gutierrez. I am the president of the Kawasaki Disease Foundation, United States. I want to start by thanking Elizabeth and Karen from Kawasaki Disease Canada on behalf of the board of directors from the Kawasaki Disease Foundation for their collaboration in bringing this session together. We are truly honored and excited to be here and anticipate more fruitful collaborations. I also want to extend my heartfelt thanks to our next presenter, Annette Baker, for graciously stepping up at the last minute to share her remarkable work and serve as a valuable resource for all of us. Annette has been a nurse practitioner on the Kawasaki disease team at Boston Children's Hospital since 1989. For the last 35 years, Annette has met with each family whose child has been diagnosed with Kawasaki disease in order to provide education and follow-up. She was a participant in the 2017 scientific statement for KD and was a member of the AHH Committee on Kawasaki disease, endocarditis, and rheumatic fever for 2 terms. Annette has published many educational and scientific articles on Kawasaki disease and has been involved in several multi-center clinical trials. She has also developed a coronary artery team, which is able to provide multidisciplinary opinions for patients with coronary issues, including those with KD, resulting in significant coronary artery aneurysms. I will now hand over the floor to Annette and Dr. Truong, who will open the floor for questions from in-person and the online sessions.
I'm ordered. That.
Perfect. Put it down there. Okay.
I guess we want to take questions from.
That one first.
Oh, you have one?
Yeah, well, we want. We can.
Yeah, I think we should start with in-person questions. So if anyone has questions.
Richard.
John, thank you for your very well laid out step-by-step process, because as an advocate, I get a lot of calls and messages from parents who really are struggling with it. And I also, being a long-term survivor, who thankfully has lived to 73 trips around the sun and about to get my 74th, I can tell you that whenever I go in to see my cardiologist, they're kind of surprised I'm still there. And I struggle to explain to them what I learned at these conferences, because they kind of look at me like, well, we don't see that many adult KD patients, let alone somebody who has lived as long as you have. So my question really is, at the moment, parents do still struggle with trying to get their children transition into young adult and adulthood. And I get questions more and more, and maybe we can all think about this, is I'm getting more and more questions about neurological issues that manifest much later. And I think COVID-19 has brought this out with the long-term issues. It's not just a cardiac issue. There are other things like Ehlers-Danlos. Dr. Burns, in her long-term study, asked the question, have you been diagnosed with Ehlers-Danlos? I've never been diagnosed with Ehlers-Danlos, but when I saw that as part of my follow-up, I asked the question and did a literature search and actually found a lot of material that's now going towards that. And the reason why I'm glad Annette Baker is involved now is because she sees all these kinds of patients. I think you've actually treated some patients with POTS and also looking at dysautonomia based on what I've heard. So those are things I think we need to kind of ask ourselves the question, have we heard this? Have we seen it? Should we be on the lookout?
Okay.
We're going to pass you the microphone.
Oh, okay. Great. Thank you.
It should be on.
Okay. Sorry, you can hear me?
Yep.
Oh, okay. So I think that's a great question, and I think it's one of our unknowns. And I think it's something that we're all kind of navigating together. I think just because, first case diagnosed by Dr. Kawasaki, 1960s, 1967, I think for the older patient, I think we're still learning about what are the long-term sequelae. We know that in Kawasaki disease, it doesn't just affect the heart. There have been several studies that have shown, having potentially aneurysms elsewhere. It's a medium vessel disease, so it doesn't just affect the heart. And so I think, I wish I had an answer for you right now in terms of what to expect. And I think time is going to tell. And I think, unfortunately, I think there's still many patients who maybe had Kawasaki disease who haven't been diagnosed. So getting that true denominator of the number who've been affected by Kawasaki disease and kind of looking at how the long-term effects of Kawasaki disease is somewhat going to be difficult over time. But I think long-term follow-up with care providers, and I think being able to identify patients with Kawasaki disease will help us in our understanding. Because I think only if we all kind of pull together, both patients and researchers, can we really get to that, those answers of what is quote unquote expected. You had mentioned POTS. POTS, actually, we see a fair amount within cardiology and teasing out how much is related to the history of Kawasaki disease versus, quote unquote, typical teenage female. I think, again, we're going to have to study formally. It's hard to say just anecdotally, but I think anything is possible.
And I was just thinking, I think the most important point of that question is the development of teams that work together, because certainly at Boston Children's, at bigger centers, we've developed Kawasaki teams, and then our numbers are still, even though they're larger than other places, they're still too small to make any definitive statements. And so places like the International Kawasaki Disease groups that can pull together information, some of the multidisciplinary studies. And before I end this career, my big goal is to make sure we have a really good transition team of a group of adults that understand Kawasaki disease, because what's happening is our kids are scattering to a lot of different adult cardiologists, and it's difficult and it's going to happen, but it's important to have kind of central databases and teams of people who understand both Kawasaki disease and adult coronary. And so it's a process of reaching again across the street, reaching across the aisles, trying to get our pediatric teams to work cooperatively with adult teams. And that's easier to do in a place like Boston or Atlanta or a city, San Diego. And it's harder to do in rural, Tennessee. And so I think what's happened in the last 10 years is really the availability by internet and all the kind of online uses of imaging and so on, that we can begin to kind of coalesce all our data together. And that's going to be really important for adults who have had Kawasaki. So it is working. Yeah. Yeah.
I have two questions. The first one is, as a parent nonprofit organization, we have been working on getting more resources and information on the website of Transition to Care. We're currently working on a pamphlet that our KDS youth created, and we're trying to get the information out there. But is there any other ideas you have on what we could do to help kids transition into care? Because aside from the information, I don't know if that's enough. My second question is, one of the things that we always get questions about are from parents who either they move out of state or they don't have a cardiologist in their area that knows about Kawasaki disease. And they reach out to us asking if we know anyone in their area, and we don't. And even if we did, there's times when parents are not able because they don't have the resources to travel, like to Boston, for example, to get the care. Is there any way we could collaborate with either you or some of the other clinicians to come up with a pamphlet that's written by doctors for doctors to educate them? So at least we can have some type of information. If a parent reaches out and they're like, my cardiologist doesn't know about Kawasaki, what do I do? We could try to say, hey, maybe this information would help them. And if it's coming from a doctor, I think it has more weight than if it's just coming from an organization who's not, medical professional.
So sorry, can I ask a clarifying question, please? So when you said they move, is this during pediatric care or adult care, or it doesn't matter?
Sorry, if some of them either they have moved from different states, like Kate moved and she needed a cardiologist in her area who's an expert, or some of them just don't have a cardiologist in their area who are experts and they're new to Kawasaki disease and they want to find someone who knows about the disease for their children.
Okay. Thank you. Thank you for that. Okay. So I think, so not every center can have an Annette there, and they are going to be at larger centers. But I think that what Annette just said in terms of accessibility and I don't know if it's second opinions or reaching out. Most, I would say, pediatric cardiologists at some point in their training do see Kawasaki disease. They might not be an expert, but hopefully can help in diagnosis with local pediatricians and that sort of thing. In terms of like the more complex things like the coronary changes, anticoagulation, that sort of thing, many large centers do have ways to reach out. And I'll let Annette talk about Boston's program, but I think many of us are happy to answer any questions from other providers that reach out to us in terms of opinions and that sort of thing. So hope that answers the question.
Yeah, the last set of guidelines kind of tried to organize recommendations for long-term follow-up, but they are very broad. They really are. But there will be iterations of that coming out. I think that in terms of ability in everyone's region of functional testing, of how frequent the testing should be, of treatments, of use of anticoagulation, that has changed a lot. And it changes first in the larger centers and then it trickles out. So availability of those kind of resources in a real, knowledgeable fashion, because there's a lot on the internet. And you have to be really careful what's on the internet. So I love the parent groups. And I think if you kind of vet your information through physician groups to make sure that the information out there for parents is accurate. And a lot of centers have the ability to do kind of opinions when decision-making is necessary. So say there has been a change in functional testing, an intervention is or isn't recommended. A lot of parents now are very savvy at reaching out to the larger centers. And a lot of the larger centers do have a process. And we've kind of formalized that. I'm going to talk a little bit about it tomorrow, but we formalized that process because it's very hard to get emails on an incidental patient without all the information and comment on it. So and I know many centers have streamlined kind of, our opinion process where we really need the imaging, we need the question. They can come from parents, they can come from physicians. And I would say we get tons of questions from physicians. So when physicians are not comfortable and want more information, they often reach out. That's a very common thing to do. But in order for us to be able to give an opinion, I'm sure this is true at your center, we really do need the clinical data and the imaging data. And now you can share imaging data with groups of specialists online at Zoom conferences. And it's actually wonderful. I think it's just going to increase, But I think the information that you put out there for parents, which has been very medically accurate, is very, very valuable and very important. And as we get more data in adulthood, we'll be able to kind of push that forward, I think. Yeah.
Well, so I had a follow-up question just on that kind of went along with that, but also on a personal note. So I was in a situation where I had Kawasaki disease at 15 was quickly transferred to an adult cardiologist who knew Dr. Newberger. And so kind of had that transition there, and then moved to Seattle, was followed by very, very good doctors, very knowledgeable doctors. Now I live in Savannah, Georgia. Walked in to a cardiologist's office and they said, I don't know anything about Kawasaki disease, but I'm willing to learn. And I said, that's not good enough for me. I need somebody who actually knows. So now I'm currently being followed at MUSC in South Carolina. Still not great. Is there a set amount of questions? I'm thinking a lot about these kids who are older, who are going to have to start advocating for themselves, setting up these appointments. Nobody can be tied to one place. I moved because of family circumstance and because of COVID, you know, and we wanted to be closer to family. So is there kind of a set amount of questions, guidelines that we could provide to, like on our website, if you're interviewing a new doctor, here are certain things that you need to ask to make sure that they know, because we all know there's a lot of doctors with very big egos who they see a case that is new to them and they want to be the one that fixes, and they might not have the knowledge. So
I think that I think there are some general questions that can be asked. And again, depending on what the answers are, can kind of move along the way. But I think certainly one of, you know, it sounds like you asked, have you ever seen a patient with Kawasaki disease before? And if they say no, I think then it's a question of, sounds like that cardiologist was willing to learn. It's hard to learn about a whole disease in a little bit.
Yeah.
But, you know, in center, and again, not everybody has the ability to go to a center outside of their town and that sort of thing. And I think patients have to look at what their resources are and what can be swung. Because I think it would be fantastic if everybody, all of our adult Kawasaki disease patients could be followed at a center with an adult congenital heart disease cardiologist who's trained in both sort of pediatric cardiology and adult cardiology. I think that would be the ideal. But unfortunately, ACHD docs in general are at limited supply at this point. But again, there are adult cardiologists who have been interested in Kawasaki disease and who have worked with patients with Kawasaki disease. So, you know, I think, again, asking how many have you seen and what sort of resources are there for, you know, if I was to come in the middle of the night with chest pain, what would steps be to kind of for my care? Also, you can also give them the 2017 AHA statement as well. But I think it's important to find someone that you feel comfortable with, and some who might not have all the knowledge you might feel comfortable with because they're willing to learn and have a great manner, etc., and are smart. So
I think, and this is probably a little off that track, but the biggest difference I see when, and I don't know if this is true for you, but when children, really any children with chronic disease, graduate to adult providers is the lack of involvement of the parents, which has to naturally change. But that's really hard for everyone. That's really hard for everyone. And kind of empowering the patient themselves with the knowledge, because they may have been blissfully unaware of what was going on from the time they were 6 months old till they were, you know, of age. And so, you know, that kind of partnership also changes a lot with adult involvement, because a lot of adult practitioners don't want an additional parent there, or you may not want an additional person there. So some of that knowledge I feel like gets lost, and that relationship gets lost, and new relationships have to form. But I do think in speaking of what Nam also spoke of, is that there's always been this difficulty. Is it the congenital heart doctors, which we're very comfortable working with, but actually you don't have congenital heart disease, right? You have acquired heart disease. So who is the right provider? And it may well be an adult coronary person, but you want the availability of an interventional person. You want the availability of a good coronary surgeon if you need it. You yourself want to know the signs and symptoms of concern. And you also want to know kind of the latest in terms of, I guess, anticoagulation, antiplatelet therapy. So, you know, there are a lot of pieces of education that do end up with the patient. And then I guess with adult providers, you want to make sure that they do enough functional testing. We do a lot more than adults do, would you say, as pediatric cardiologists?
Probably.
We probably monitor kids much more closely. And so that's something a little bit to get a little bit more used to, I think, as you become an adult. Yeah. A lot of adult providers don't intervene unless there's symptoms, and I think we do a lot more imaging. As you become an adult, you have less imaging. It's my sense. I don't know if that's your sense. Yeah.
I think so, and I think potentially the guideline statements do kind of help to enforce. No, I shouldn't say enforce, but that it's not just a parent or a patient talking. This is groups of experts, familiar, you know, who are experts in Kawasaki disease. This is what is recommended. And so I think that knowledge is important because, in all honesty, adult providers probably don't even know that guideline statement exists.
I didn't know.
So
Now, I can justify the fact that
yeah,
when I take them back, say 2017,
yes,
they kind of look at me like, wow, I didn't know this existed.
right.
I just want to chime in.
We're just going to talk about this. Sorry, because we are recording this for Zoom too, so thanks.
Okay, so I had the same experience as you, but some years earlier in a city where I'm sure there's no Kawasaki disease expert, but I think the difference is that first I went to a doctor, didn't know anything, and then later I did find a doctor who said, well, I don't know much about this, but I have looked up these AHA guidelines, and I also think that we should talk to this Dr. Newberger in Boston, and do you have the means to go see her? So I think there's a kind of doctor who doesn't know that much, who could still be a good doctor if they're willing to do some homework and kind of acknowledge that they don't know everything and be in communication with the people who are experts, who I found to be very open to communication from physicians out in the world. You know.
Oh, I was just going to say, I think it's a lot of your own comfort level too. If you have the means and you would like an expert, I think that's great. But again, it's kind of what situation are you in? What are your needs? What are your resources? And kind of figuring out what fits for you or your child in that situation.
And it's not only cardiologists. I mean, you know, if you want to have children and you have giant aneurysms and you're on medicine, you know, you need to be hooked into high-risk people who have that knowledge as well. Most large cities do have adult programs for children born with congenital heart disease. And so some of those high-risk programs are in place in many centers that may not be too far from people, but it's a bit of fine-tuning that goes on, sure.
Are there any more questions of the in-person? Oh.
Hi, I'm Nina. My role is same as Annette. Actually, at some point I was trained by Annette when I finished my master's. Anyhow, what I wanted to add to Annette's comments, we recently did a transition qualitative study interviewing young adults, asking them what their challenges were and what, like, you know, echoing the same concept. There were some females, like it should be a multi-D sort of team involvement, and patients should be aware of that involvement, even though we go through stepwise educating patients. So their key points were that they do get trained, they do get education, but at that point they are with their parents, they don't pay attention. And so there should be a health class for which we know that, that's a component of transition. But it was eye-opening experience of two females that they were on anticoagulation and platelet therapy. And at the time of for the daughter's health, they were asked for some procedure, and they had to stop your aspirin and Plavix. And actually, those patients, they were aware that they had that concept built in that I can stop it. So from my learning curve, they say always adult team has gynae department, and they do have a board protective health with congenital patient population, but there should be an established team as like when someone is developing a pamphlet, there should be some kind of identifier so that that is not missed, so that it's like, yes, healthcare providers should be vigilant about it, but our patients should be also educated so that they can, like 2 examples, they can advocate for themselves.
We go to the next question. Sure. Did you have one from online?
Yeah. So the question in the Zoom, we're going to ask kind of both of them together. One, is there a current registry of KD experts that treat KD patients as they reach adulthood? If not, just have a side note, there should be, so let's work on that.
Yeah, I think the answer is no, but yes.
And then someone is asking specifically any adult KD doctors in the Florida Gulf Coast that you know of, or
we could find that out. Yeah, we can find that out for sure. I agree. I mean, and to be honest, we're trying to kind of cultivate a team that is available, not at a moment's notice, but in quick succession for issues that come up. We have that for kind of pediatric coronary, and we have been, pediatric imagers may not be like we do a lot of our nuclear medicine tests over at the Brigham with our adult colleagues. They've been amazing at stepping up to they've been really interested in coronaries in children. The kind of coronary issues that we see are much different than what they see, but they've been invaluable. And same thing with the cath people over there at the Brigham and the BI. So we've kind of cultivated, and I am talking about this tomorrow, but basically MISC prompted us to do this in a very formalized fashion because people were working at home. Not everyone was available. And so we started kind of doing distribution lists and making organized meetings and Zoom conferences and collating data in a way that we had not before. And I just think that's going to get better and better. And but I don't think that there's a list of adult KD doctors. I mean, John Burns was one of them, but he's retired now. There's not John Burns.
Gordon.
Jane Burns' husband. Sorry, Jane. Sorry. Anyway, he's done a lot of work in the adult world. But yes, we do need, as this population, I actually looked at our data the other day. In 2018, over 55% of our patients in Boston were over 18. And I've actually just asked them to update that, but I would assume it's going to be, probably 2/3 of our patients or adults now. And so it is a sorely needed expertise that I don't think we have.
So I'm actually going to ask a question that was submitted in a survey that we did earlier. And so we're going to switch tracks a little bit because it's now I'm going to ask more about the non-aneurysm patients, because up to now, a lot of it has been about aneurysm patients, which are a very important population. But I think one of the things we get asked all the time, I think is a bit controversial because the answer to this may differ from where you live in the world. I know both of your expertise has been in the US, but I know in other parts of the world it might be a different guidance. So one of the things we often get is how often should my child see a cardiologist or other care after diagnosis with no aneurysms? They're talking about monitoring teen and adult life. If they have no, let's assume they had no dilation at all, never had aneurysms, uncomplicated treatment course, discharge. discharge complete from the hospital, but what should the follow-up look like? And I guess the second part to that is some people do ask about calcium score. They've heard about this thing called calcium score getting done, but they don't know how to broach this topic with their GP. And again, I think this is very center-based from my experience. So I don't know if that's a loaded question, but that's the question.
I'll start with the beginning part, and then I'll let you fill in the blanks. You know, I'm old, right? So, I've been doing this since I was 30, I guess. I'm 65. So at the beginning, we saw everyone initially at 1 to 2 weeks, 4 to 6 weeks. Then we'd see them at a year. Then we'd see them at 5 years. Regardless, this is patients who never had coronary aneurysms. So we didn't use Z-scores back then, but all coronary dimensions were within normal limits. So we'd see them at 1 year, and then we'd say, you're in great health, you're doing great. Oh, but come back in 5 years. And then we do the same thing in 5 years. And so you're giving patients a lot of mixed messages, but those were mixed messages that we needed to sort out. We needed to see 50 years of data to make sure that those patients who were always normal were not having late events. And from what I understand, and you can fill in the blanks, they are not. And they are looking in population studies just like the normal population. We do now, the new guidelines in 2017, which are now 7 years old, no longer recommended long-term follow-up of those patients. And so we see them initially at the 1 to 2 week follow-up, at the 4 to 6 or 6 to 8, kind of get them through that acute. And if you've never had coronary dilation during that time period, then they are discharged. We stop the aspirin, and we do counsel on good coronary health. So that means not smoking, that means regular exercise, maintaining a good BMI, eating a heart-healthy diet, routine cholesterol screening, which is now recommended for all American children between the ages of 9 and 11, and then again before high school ends. So I think if you do all those things, we have not found long-term negative outcome in those children. So, and with the use of Z-scores, we are following everyone, even with a lower bound of dilation. So probably those children who fall into the 2.5 Z-score to 5 are also doing very well, but we are still following them at this time. But we have very positive, kind of encouraging results for everyone who had Kawasaki disease who never had aneurysms. And you don't want to create non-cardiac disease in those children. You want them to be active, no activity restrictions, live a normal heart-healthy life. They do have probably a slightly higher risk of having an offspring that may develop Kawasaki disease. Again, very small, but there have been some studies in Japan that have looked at that. And of course, if you've had Kawasaki disease once, you have a slightly higher risk than someone sitting next to you who didn't have Kawasaki disease of having a second episode. But again, in my career of over 2,000 patients that we've seen, we've had about 12 or so who've had second episodes, and half of those have been Asian. So the number is small, not zero. But that's kind of what I tell patients who don't have any coronary involvement ever. I don't know if that encompasses most everything.
Yeah, I totally agree with Annette. In Utah, where I was before I recently moved to Atlanta, prior to the 2017 guidelines, we also were seeing kids who've had no coronary artery changes every 5 years, partly, just to check in, but also informing them if new data were available and that sort of thing. So multiple reasons that we were doing that. But I think with ongoing data from countries like Japan showing that patients, for the most part, who without coronary changes were doing pretty well. And actually, Dr. McCrindle's group within the past 2 to 3 years just published sort of a population-based study looking at kids with Kawasaki disease with up to 27 years of follow-up, and it included those who did not have coronary artery changes, whereas most prior studies had kind of excluded that population. But there was a slight increase in hypertension or high blood pressure long-term, but that sort of, and they compared this to a control group of patients who did not have Kawasaki disease, and when I talk about a slight statistical increased risk in high blood pressure, it was like 2.5% in the non-KD group compared to 3.7% in the KD group. So pretty low increase in risk of blood pressure. And after like 13 or 16 years, that increased risk went away. So overall, it seems like kids who've not had coronary changes live pretty normal lives, pretty similar to if patients do not have Kawasaki disease.
I didn't address the calcium score.
Oh,
I'll leave that to you.
Yeah, so calcium scores, there's still ongoing research within calcium score and the use of and its utility in Kawasaki disease. So I think more data in the upcoming years, I suspect we'll have more. I think depending on the age of the child, because most calcium scoring, I think at this point is done within adult centers. I don't know if you guys are routinely doing it at Boston Children's, but it's done a lot in the adult world in terms of risk stratification for, adult onset heart disease. And I think we're still trying to kind of figure out its utility within Kawasaki disease. I've had some adult cardiologists say everybody as an adult should get a calcium score, regardless of whether or not they have any sort of risk factors for heart disease. But nonetheless, I think finding the center that's willing to do that in a child, I think would be a big potential barrier to getting it done. But I think in terms of broaching it with a pediatric cardiologist, I don't think there's ever any harm in just asking them, so what do you think? But to my, reading of the literature, I think we're still kind of sorting out what to do with them in kids with Kawasaki disease. It's not prime time yet, so, but that may change over time. Anything to add to that? No.
So we had a Facebook Live question come in. How many follow-ups for an adult KD patient with multiple coronary aneurysms?
I'm sorry, say the question again.
How many follow-ups for an adult KD patient with multiple coronary aneurysms?
How many follow-ups?
Would
like in a lifetime or?
Yeah.
Yes, it would be lifetime.
It really depends on the size. It's so individual. Yeah.
Yeah, but if they have giant aneurysms, whether or not they've resolved or persist, would be lifelong follow-up.
Yeah.
If I'm understanding.
And typically, of course, it depends how big the aneurysms are. The biggest we would probably see, every a couple times a year. Yeah, twice a year, with functional testing at least once a year, surveillance for thrombus and function and so on. But it is divided in the guidelines between your worst ever and your current status, and that will evolve. I mean, that was kind of a first pass, and I think that will evolve as new iterations of the guidelines. Every situation is so individual in this illness.
I'm just going to ask you to speak up a little bit because the translator's having trouble
sorry.
hearing you. That's okay, but just to,
Yes.
and then, yeah. And I think the question was just a little bit different. It was who don't have visible side effects. So if other than cholesterol screening, healthy diet, exercise, are there other screening or follow-up tests for children who don't have visible side effects?
You mean no coronary changes?
Correct.
For children with no aneurysm, never, then it's good pediatric care, coronary health, hypertension, lipid screening, heart healthy diet, regular activity, but no further cardiology follow-up after they're kind of 2 months out.
And I would say that if patients that I've cleared from cardiology follow-up because they've never had coronary changes, I always tell the families, if you ever have new questions or concerns come up from a heart standpoint, feel free to reach out to us again. We're completely happy to see kids back if something comes up or there are concerns.
And what questions too? Someone had asked a question. Does the KD department have a liaison with the Navy or Marine Corps to help Navy medical understand what KD is and the care plan that comes with it? That way they can classify exceptional family members accurately so the service member's dependent is taken care of.
I don't think so. Do they?
Sorry. So the question is there a link between Navy medical providers and KD care teams? So actually, we recently trained an Air Force fellow in pediatric cardiology. So there are pediatric cardiologists trained within the military periodically. I agree, and I don't think there's a clear link in terms of, but so if a family is within the military and they're having struggles sort of finding care, I would say a couple of options. And again, I don't know if it's pediatricians they're seeing or adult providers who, based on where they're living, there isn't a pediatric provider. Depending on where you live, again, I think there's the option to reach out to a larger center just for help and support if having difficulty. I'm not sure if that really answers, but
yeah, I'm just trying to think back if we've taken care of anyone in the military. I mean, there have to be military children who've had Kawasaki disease. But I don't know of any direct link. Yeah, but we're happy to weigh in if anyone wants us to.
Yeah.
We started 10 minutes late, so we're going to go 10 minutes longer, and hopefully that will be the rest. The next question is actually would seem quite to be a basic question, I would think, but surprisingly something we hear over and over again, regardless of what's on the internet. And especially with Kawasaki's patient parents are very on edge. If you dealt with them, you know, because they hit with something they never either heard of or never expected. So they kind of continue to have that paranoia, I may want to call it. So they always ask about how the spotter occurrence, which you did mention there's a chance, but it's low, but also how to react to other fevers or illnesses, because I think I can speak for most Katie parents that they're on high alert the next time their child has a fever and constantly checking them. So what words of wisdom would you have for those parents?
I mean, typically a second episode is similar to the first. So everyone's going to get sick again and everyone's going to get fever again. And it's really when the fever goes on for, 4 or 5 days plus the other symptoms evolve. I think that your primary care should always know that your child had Kawasaki disease, so they're a little bit on higher alert. But there are very specific things with the symptoms, like, you may have a rash, but it's not vesicular, or, it's vesicular and it's not likely to be Kawasaki. So I think it's really a matter of kind of, surveillance, right? And checking in with the pediatrician as frequently as you feel comfortable so that diagnosis can be made. I have to say it's never missed the second time. And it's usually diagnosed sooner. And sometimes we're not sure. And sometimes because the child has had a first episode, we may be a little more comfortable treating a child for a second episode that may be incomplete, maybe a little bit earlier than we would have the first time. So I do think all those things in parent awareness is huge. But the one criteria that's never missing is fever. So, and it's really that prolonged fever. Most other illnesses run their course in a little bit shorter time. But any words of wisdom there?
Yeah, just echoing all that, I think what I often tell parents about this rare but potential occurrence is, what to look out for now. And I think in pediatric literature in general of kids who've gone through hospitalizations, there's almost like a PTSD component to things. And I think we're starting as clinicians to recognize that more. But I think a lot of our parents have advocated for their children before. And so I can understand why things like that would make you on high alert. But as Annette said, luckily, it's going to present like Kawasaki disease with the symptoms of Kawasaki disease. And again, we might check labs earlier and that kind of thing. We might be a little bit more quicker in the process, but kids unfortunately get a lot of viruses and that sort of thing. And I agree with going to your pediatrician. If there's ever concern beyond that, feel free to call cardiology or who had been following your child to discuss further.
Yeah, you are at a bit of an advantage the second time, although you never want to have a second episode. But my guess is that a lot of people don't even know what Kawasaki disease is, and you do, and you've been there. So it is very rare to miss a second episode.
So there's a question that just came in. Is there, can you have a recurrence in adulthood? I haven't personally seen it. I feel like I saw some case reports, but again, I think one of the interesting things, especially since we don't have a test to definitively say you have Kawasaki disease or not, there have certainly also been reports of patients who were diagnosed with Kawasaki disease and then over time developed some sort of recurrence. And then it turns out that, they get diagnosed with some other autoimmune disease, and whether or not the initial illness was, truly Kawasaki disease or the initial manifestation of a, more chronic autoimmune illness, I think is a little bit up in the air, but I personally have not seen anybody who's had a recurrence in adulthood.
Yeah. I think 75 to 80% of kids are under 5. And then there is a tail, and I have seen some sick 11, 12-year-olds. I saw one 17-year-old, but most children are not, I haven't seen them adult.
So actually it's a good segue because you mentioned other diseases that look similar, because that's another question that we get often. And I think it's something you mentioned earlier about still not having the long-term data on some of the adults. But the question is there any known correlation between the history of Kawasaki disease and other things like arthritis or junior arthritis or high cholesterol? I know we talked about POTS earlier, or periodic fever syndrome is another one. I get a lot of parents asking me. So is there any research that supports there's a correlation? I know not just causation, but correlation for any of those type of things? I know that's more of a rheumatology thing, and unfortunately Dr. is not here, but I'm hoping that you still have some word and wisdom for that.
I mean, sometimes at the beginning they do, but there is overlap. And sometimes children who we thought had Kawasaki disease have gone on to have other illnesses like JRA. But I think then in retrospect, we thought that they didn't probably have Kawasaki disease. As far as we know, Kawasaki disease is an acute systemic vasculitis, and it's not a long-term chronic illness. It's the aneurysms and so on that are the chronic long-term issue. But the inflammation subsides and it is considered to be an acute illness. But we have been fooled, and we have treated children who ultimately end up having other things. In terms of cholesterol, the reason we check cholesterol is not that Kawasaki disease causes high cholesterol, although when you have a febrile illness, it can, in the short term, affect your cholesterol, particularly your HDL can be lowered. But in the long term, Kawasaki disease doesn't cause hypercholesterolemia, but both things can affect the coronary. So in a patient who has coronary aneurysms, you want to also make sure the cholesterol is not high, and in general, want to promote coronary health. Having said that, we use statins in children who have aneurysms for other reasons, but I don't think it's a cause and effect.
Yeah. And so what I wanted to say was, we do think that there is some genetic basis to Kawasaki disease, and we don't know what that genetic, there's certainly certain genes that have been linked to Kawasaki disease. We certainly haven't mapped all the genes associated with Kawasaki disease at some point. An interest of mine is, do patients with a history of Kawasaki disease have family histories or higher, greater family ancestry of things like rheumatologic illness and that sort of thing? study I'd like to do in the upcoming years, sort of where we can get to that data. But, you know, I think I have nothing else to add to Annette's comments.
I have a lot more questions, but does anyone in the room have a question that they'd like to ask before I continue? No? Okay. Yeah, I'm gonna switch gears a little bit, and now back to the aneurysm patients. So we had a question come in, and I know, again, this might be difficult to answer because it's a bit open without knowing the patient, but they basically asked, when is the best time to fix the aneurysms, and what surgeries should one expect?
I'll give it so to the cardiologist, but unfortunately, yeah, we can't fix aneurysms. We can try to make sure the blood flow goes to the right place if we're seeing signs of ischemia, but today I don't think we can fix them.
Would agree with that. And in terms of the best timing, I think it's going to depend on the patient in terms of what coronaries are affected, what sort of, how was the lesion or how was the ischemia discovered? Was it through routine testing? Was it symptomatic and then led to routine testing, that sort of thing? I think there are a lot of factors involved, again, in how I'm not a cardiac surgeon, so how straightforward is the intervention to provide adequate blood flow and weighing all the risks and benefits at the time. And I think the type of intervention that is done will depend on what the lesion looks like, you know, coronary stenting versus the bypass surgery. And that's where, again, as Annette had mentioned earlier, multidisciplinary discussions between cardiac surgeons, cath teams, the medical team, in terms of what's the best approach for the particular patient based on the testing and how the coronaries look. So.
Yeah, it's not an easy answer, and parents are often like, can we just bypass? But if you bypass the vessel with good flow through it, bypass isn't going to hold. So it is a very individualized recommendation.
And unfortunately, luckily, not, you know, most centers have scattered cases here and there of, you know, myocardial ischemia or heart attacks, luckily. And so actually having any sort of evidence-based recommendations is in some ways good that we can do that. So just expert thoughts. And again, everybody is so individualized in these very difficult cases.
I'm just going to add something to that because I think the theme of what we've been experiencing in IKDS is a lot about collaboration. So my hope as a parent of a child with Kawasaki and with aneurysm is that those registries that we talk about, that data is a huge part of collaboration, but getting it, but being able to extract it and the doctors being able to see, okay, I've had patients similar to that. I can look in here and see, okay, do I stent him? Do I bypass him? Or what the outcomes have been for those patients. So I'm not sure how far along we are on that project. Like I know like IKDR exists, but I don't that kind of data is in there. And I think that's something as a parent and patient we would love to see because that's the best way to collaborate. Like use the data for something that's going to provide the best outcome, right? Which is what we all want. So and then the next question is about anticoagulation. So we've had questions about the long-term usage of well, DOACs, which I know anywhere some of you don't have long-term data, but I know Annette knows a lot about DOACs and aspirin or Coumadin and what kind of side effects children can expect in the long term, because as we know, a lot of these kids are taking it from when they're infants and probably for the rest of their lives. So I think parents are concerned about what are the things we can expect in terms of side effects.
So as you mentioned, Karen, with DOACs, we don't really have great long-term data yet in terms of long-term side effects. In terms of aspirin, for pediatric cardiologists, it's like we want to put it in the water. We have patients with congenital heart disease on aspirin. We have a lot of, well, our Kawasaki disease patients on aspirin. So in terms of side effects, at the dose that we're using, very minimal side effects, maybe a slight increase in bleeding, but otherwise pretty well tolerated. And again, make sure kids get their flu vaccine for that theoretical risk of Reye syndrome, etc. With things like warfarin and Lovenox, again, the biggest thing, especially we worry about, our younger kids on anticoagulation with falls and the bleeding risks associated with those falls. In terms of long-term risks of Coumadin and Lovenox, nothing that I can think of that we monitor per se in terms of end organ function. That being said, for women during pregnancy, your anticoagulation strategies will be altered during pregnancy, or might be altered during pregnancy, because Coumadin during pregnancy is not great. But we don't do any specific end organ monitoring
I think for chronic Coumadin use, we were a bit worried about bone health as you get older. However, there was an old study that I did that looked at the amount of time that you're actually in a therapeutic INR range in Coumadin was about 2/3 of the time. So we actually, have switched over to DOACs, mostly a Pixban in our institution at this point, and that history is being written, I think, to see how kids are doing long term. But of course, the bleeding risk is what we're going for, right? So you don't want someone to clot, but then your side effect is going to be bleeding. So that affects the child's life, I think, almost more than a lot of the other things in Kawasaki disease, because the other things we're monitoring over time, but on a daily basis, the risk of bleeding is real in a young, athletic child who's on dual, antiplatelet, anticoagulation therapy. So it's a balance. It's a balance.
Actually, segues another question. I had a parent ask me about, apparently they had 2 children. 2 of their boys had Kawasaki disease. One was treated right away, and there was no signs of aneurysm, but their oldest was missed and treated late and now has aneurysm. So they're asking if they can play sports. Apparently no cardiologist would clear them. So apparently either of them, even though one has no involvement.
So from our perspective, there would be no activity restrictions in a child without aneurysm, and activity would be good. And for the child with aneurysms, there would also be no aerobic activity restrictions if there weren't any concerns about function or ischemia. So I can't comment on that one individual child, but the restriction that would be in place would be in anyone who's on a dual antiplatelet anticoagulation would be avoiding sports that have a high risk of physical injury. So it would be hard to put a boy into football or girl into football if they were on a DOAC or a Coumadin or Lovenox, because you're going to get kicked in the stomach or hit in the head. Those are the things you don't want, but you do want a child to be active. And activity actually may help promote the growth of collateral vessels. So we try not to restrict activity except based on bleeding risk, if we can help it, depending. I mean, obviously, if a child has had an MI or had cardiac involvement, that's a whole different story, but in general, with good function, no ischemia.
I agree. And actually, early on for the patients diagnosed at a pretty early age who have significant coronary artery aneurysms that are in the giant category, kind of talk about that early on, because it's awful for a child to love football, and then all of a sudden needing to take it away because, oops, you're on the anticoagulation. So I discussed with families early on, maybe steering the child to sports where, that are contact sports. So that, and obviously some families are big football families. So I think it's finding that balance, but we certainly want to encourage safe activity.
Great, thanks. Sorry, I'm actually going back to something you said earlier about aspirin, wanting to put it in the water, because I had 2 questions. One, they just asked, what is the evidence for lifelong aspirin usage for patients with regressed aneurysms? And then well, I guess actually it's the same question, because this child apparently had giant aneurysm, and fortunately for that child, his latest cath showed no aneurysms anymore. So they're asking, is it necessary to continue taking aspirin? And the second part was there any hope that there will be a study that the heart or the arteries can come back to normal? Which I know one of your slides already addressed that. But so is aspirin usage still recommended in this patient?
Yes, so in patients who've had giant aneurysms who have regressed to normal dimensions by echo, current recommendations are to aspirin for life. And to my knowledge, I don't think there are studies showing that, reduction in events, and again, luckily because events are rare, and a lot of that is expert feeling. So again, as I mentioned in the talk, the worry is that even as the coronaries regress to normal in size, if they do, they're not normal, and that there could be thickening, and the actual pathway for the blood flow to go is actually pretty narrow. So aspirin will help to thin the blood to hopefully decrease increase the ease at which those red blood cells travel through the vessel. But I don't think there are any studies comparing no aspirin long-term to aspirin long-term in cases who've had regressed coronary aneurysm. Are you aware of any?
No, I agree. And also your risk of stenosis does continue to increase over time in that particular group of patients. So, yeah, I think it's maybe a small price to pay to ensure patient, promote.
Actually, something you mentioned earlier about women when they get pregnant. So someone was asking what precautions and actions should women with sequelae take during pregnancy and childbirth?
Well, that's a big question. It really depends on how big the aneurysms are, what meds you're on, what the function of your heart is, and all those things. And so I think each case is very individual, but there are certain medications that you cannot take during pregnancy that have to be modified.
Correct. And I would say if there's a woman who's thinking of getting pregnant, who's on anticoagulation or has a history of aneurysms or significant cardiac sequelae, talking to your OB and your cardiac team potentially even beforehand and have to be a plan. So obviously surprises happen, but yeah, kind of discussions early on, and hopefully discussions are happening as teenage girls are getting.
And high-risk OBs have a lot of experience in this because Kawasaki patients are not the only one on these medications. So I think that resource should be available a little more readily.
Actually, touching on what you just said about having it come to a teenager, there was also a question about menstruation. So I'm assuming this patient is younger, and so the parent is asking, what can I expect during menstruation because my child is on blood thinners?
So you can expect more bleeding. And we have had patients who early on have had IKDS placed, have been on different kinds of, flow limiting drugs. Right. Yeah. So it is a thing, yes.
The other thing I get a lot of questions are for survivors. So not actually with aneurysms, I think it's all kidney patients. They ask things about if there's specific foods they should be eating, on vitamins or supplements. I mean, they're really concerned about keeping their heart healthy because, as you said, we don't have the long-term data. So a lot of parents are looking for advice on how to just be extra healthy as a KD survivor.
Sure. I do the Olympic clinic to the Boston Children's. So, it's the overall heart healthy approach. Yes. Low saturated fats, Mediterranean diet. Keeping your lipids normal.
I usually don't recommend vitamins, things like that, as long as someone is eating a well-balanced diet. But yeah, besides that, I don't really make other recommendations per se.
I think everything you would do to maintain cornea health plus. Yeah.
Again, a bit of a rheumatological etiology question, but but I know we've talked about a lot at this conference, so I'm sure you can answer it. Someone asked if there's a relationship between KD, COVID, and Miss C. I know this is hotly debated, so you may be, I don't know which side of the debate you're on, but now you'll be.
Well, I mean, we didn't have a single KD patient who got Miss C, so I don't think that that is hotly debated, is it?
Yeah, as in like Katie predisposing you to develop Miss C.
Or guess related.
You know, the most inflammatory illnesses, I'll let you're the pro here.
So I feel like I've potentially learned some things about, or I don't know how much you can say learned about Katie from Miss C. I used to always have this vision that we would find this one etiologic agent or one thing that causes Kawasaki disease, like some virus that's leading to Kawasaki disease. And I think it's similar to, I think, what Dr. McCrindle said yesterday. I don't think it's just one thing. And also I hoped that we would be able to find it within the patient during Kawasaki disease. But I think something that Miss C taught me is that inciting agent does not need to be active in the patient at the time. And this idea of post-infectious or post-inflammatory illnesses, I think, kind of broadened my perspective in terms of what could be going on. In terms of its relationship, most people think that they are different entities with overlapping pathways of development. We're certainly still working out what those pathways of development are, especially since we don't even know fully how KD develops. But most people at this point think that they are distinct illnesses.
And it really did come on like a storm and kind of go away. It was quite a year or two after COVID.
We're actually just going to wrap up now so that everyone can enjoy lunch. But a huge, huge thank you to Annette Baker and Dr. Strong for being here today with us. Everything you shared was very valuable. As parents and patients, it's just wonderful to have this opportunity to ask you questions and hear it straight from you. As you said, the internet has a lot of information, but you never know what's correct and what's not. So thank you so much for taking the time to join us today. I know you're a very busy day. And we also want to thank all of you that attended and all of you that joined us online. And, you know, in the spirit of collaboration, as we said, this conference is centered around that. We also want to thank our colleagues in the room. So Kawasaki Disease Foundation from the US, the Kawasaki Disease Foundation from Australia. I can never pronounce it, but the Australian group here and the Japanese, our Japanese colleagues. So thank you so much for supporting the work we do and helping make this session a success.
And can I just say one thing? That you guys are amazing, because this is the one thing that I think we often fail at, because we get so busy clinically that we don't do enough outreach to parents on a global kind of basis. So the more you can do, the happier we are. And we really want to make sure that the information sharing continues. So thank you so much.